Hello and welcome everyone. This is the American Health Quality Association Physician Leadership Network Clinical Discussions webinar series. Today's topic is Patient-Centered Medical Home, a current state analysis. Your host today is Dr. Adrienne Mims, your chat facilitator is Dr. Sharon Eloranta, and your presenters Dr. Jonathan Sugarman of Qualis Health and Carlin Howry from the Kansas Foundation for Medical Care. Your host, Dr. Adrienne Mims.
Thank you, Jen, and welcome all of you to joining this session today. We're very excited that we're able to present the webinar series for those of you with a focus on quality improvement. I serve as the Vice President and Chief Medical Officer at Alliant GMCF and the President of the American Health Quality Association, the trade association of the QIO network that is across the country, contracted with CMS to ensure quality improvement goes forth. So today we will be having a session on patient-centered medical home, and we have three presenters that will carry us through our discussion today. I would like to introduce to you our first person, who is the facilitator, Dr. Sharon Eloranta. Sharon is the medical director for Qualis, and she has been very influential in our national network of physician leaders in moving quality improvement to the front line, not just in her state, but on a national platform. She's a fellow at the McCall Institute and IHI, and I welcome Sharon Eloranta to take it over from here. Thank you, Sharon.
Thank you, Dr. Mims. I am Sharon Eloranta. I'm with Qualis Health. We are the organization that holds the Medicare Quality Improvement Organization contracts for the states of Washington and Idaho, just to make that clear for those of you who may not be from the QIO world. And what we're going to talk about today is something that has many names and many definitions, and I think it's going to help us to frame our very short window for discussion today if we arrive at a little bit of a shared understanding of person-centered or patient-centered medical home. So I imagine many of you have seen all of these names and probably even more. Transfer med model, primary care medical home, ambulatory intensive care, person-centered, patient-centered, even health home. What do these all mean, and are they all the same? And so for the purposes of today's conversation, perhaps we can arrive at a shared mental model to go forward. So what is the patient-centered medical home? You'll notice that this resource from which the next couple slides come actually came from 7 years ago. So we're not talking about a newly emerging concept, but this paper described the patient-centered medical home as a model of care articulated by principles embracing aspirations of a number of different models, the Institute of Medicine, the Future of Family Medicine new model of care, and the Wagner chronic care model. So a model of care that rolls in all of those types of aspirations and also embodies a relationship that is desired by some of our largest employers for the employees. So that's a big mouthful of definition. Further, they go on to say, the patient-centered medical home is not simply a description of a delivery system model, not just a way of offering and delivering care to individuals and patients, but it's a political construct that takes advantage of a name that many people recognize but are not exactly sure of what it embodies, and kind of organizes it into a model that's really starting to take a grasp on the collective psyche of federal government agencies, state, local, national initiatives, and health plans. So just to encapsulate that description, we're talking about a model of delivering care that has a lot of very high aspirations and evidence-based designs embedded within it that really embodies as well a relationship between the provider care team and the patients that are cared for within it, and a political construct. So it's a pretty complicated definition. And when you get to such a complicated definition, it kind of turns into a bucket into which much hope has been poured by many. This quote, "It is likely to be the best opportunity, ... to produce the most profound transformation of the healthcare system in anyone's memory." That's a pretty big statement to make. And again, as you'll notice, this was made in 2007, and we haven't necessarily seen full-scale transformation as of this point. But it does tee us up very well for the conversation that is to follow this morning. So with this understanding that there are many definitions and even names for person-centered medical homes, who knows where the jury is? They may be out as to the model's effectiveness in contributing to these triple aim goals: better health care for patients, better health for populations, and reduced per capita cost. What we're going to focus on today is to provide you with two windows on this large and complex topic. First, we'll hear from Dr. Jonathan Sugarman, who will describe Qualis Health's national experience with the model, as well as an overview of current literature and findings around the efficacy of the PCMH model, as we have just described it. Then Ms. Carlin Howery from the Kansas Foundation for Medical Care will describe a state-level, on-the-ground application, which will include a discussion of the transformation process from the provider experience level, so getting a little more granular. Both speakers will share their expertise, advice, and resources to assist quality improvement staff in understanding the challenges and rewards of transforming primary care in support of triple aim goals. So speaking first today will be Dr. Jonathan Sugarman, who is the President and CEO of Qualis Health. And second will be, as I said, Ms. Carlin Howery from the Kansas Foundation for Medical Care, where she works in office management and consulting with small to mid-sized physician practices and rural health clinics.
Well, good morning. This is Jonathan Sugarman. Good morning and good afternoon to all of you, depending on what time zone you're in. Thanks for attending today. What we'd like to do in the very brief time that we have, about 20 minutes, is to address the two objectives that are listed on this slide and that were nicely set up in Dr. Elaranta's introduction. First, what I'd like to do is to provide you with just a little bit of an update on research about the impact of the patient-centered medical home on the things that it was intended to improve, to reduce costs, to improve quality, improve patient experience, and also improve physician and staff satisfaction. Second, what we're going to do is talk a little bit about how one becomes a medical home, both from the perspective of practices wishing to become patient-centered medical homes, and also, given this particular audience, organizations that are wishing to help practices become medical homes. So, Sharon described a set of fairly lofty aspirations for the medical home and mentioned that while the concept has been around for about 40 years, actually starting in the 60s, when pediatricians developed the concept to address the care of children with special health care needs, it was really only in about 2007 that the four large American primary care specialty organizations set forth a series of joint principles that really kicked off the current iteration of medical homes. But again, as Sharon summarized, there have been a number of very high expectations associated with that. So the question is, are medical homes living up to those high expectations? Well, the answer to that really depends upon whom you ask, and I'm going to go over several different perspectives. I won't be able to go into detail in any of these, but would like to at least convey kind of the nature of the current conversation about the efficacy and effectiveness of patient-centered medical homes. This first slide shows a report that was published by the Patient-Centered Primary Care Collaborative in January of this year. The PCPCC is a group consisting of individuals from a variety of perspectives. There are employers and health plans and medical specialty groups and other healthcare organizations, other government purchasers as well, who've kind of convened together really in many ways to serve as an advocacy group for patient-centered medical homes, to advocate to employers and those who provide and purchase care, to structure benefit plans in order to support the patient-centered medical home, to advocate to government for funding of medical homes and incorporation of the concept into their benefit designs. So they are, in fact, an advocacy group in many ways. They have a very positive spin on the efficacy and the answer to that question in the previous slide. This particular study is one of a series that comes out almost annually. And in this slide, you can see that they reviewed about 20 studies. About 2/3 of them came from peer-reviewed journals, and another third are what they call industry reports, the gray literature. They're things that aren't necessarily in peer-reviewed journal. And across the top of the little table there, you see that they looked at the proportion of studies that showed improvement in the elements such as cost reduction, reduction in emergency department visits, reduced inpatient admissions, fewer readmissions among those who were admitted and discharged from the hospital, improvements to population health, improved access, increase in delivery of preventive services, and also improvement in satisfaction. This is primarily patient satisfaction here. Now, you can see that all of the studies did not address all of these elements, but by and large, the conclusion of the Patient-Centered Primary Care Collaborative is summarized in the sentence at the top, which basically says that their view of the research is that PCMH studies demonstrate impressive improvements across a broad range of categories among those that I just described. And you can look at the percentages. The URL is at the bottom of the slide. You'll also see it listed in the website, so it'll be easier for you to move forward to. Now, others have a slightly different perspective. This is an example of a study that was, or a publication, a white paper really, that was commissioned by the Agency for Healthcare Research and Quality and published in actually 2012, so it's just a little bit old now. It was conducted by folks at Mathematica Research, and their summary, at least 2 years ago, was a little more circumspect. What they said was, first of all, there haven't been a lot of really good study designs. Some have had insufficient sample sizes, so they can't really, even if they find a result, assess the statistical significance of those results. And also they had some kind of technical criticisms of the way in which the studies were developed. So their major conclusion was they're mostly inconclusive results. They found some favorable outcomes on some favorable effects on the triple aim outcomes related to cost, quality of care, and population health. They also found a few unfavorable effects on cost as well. So although depending on the lens through which you view this, it can either be seen as consistent with the PC-PCC perspective in that there are some favorable effects, it was a somewhat more nuanced and circumspect conclusion. So that's a government-sponsored study perspective. Now, this slide shows the results from a meta-analysis that was conducted and published last year in the Annals of Internal Medicine, where 19 studies were reviewed, and the authors used a technique called meta-analysis, which kind of combines those studies together and comes up with some quantitative assessments of the overall story that's being told by those studies. And what they found is shown in this slide, that there was a small positive effect on patient experience, that there were small to moderate effects on the delivery of preventive services. So those are things like immunizations and screening for certain conditions. There was a moderate impact on staff experience as well, that there was a little bit of a reduction in emergency department visits, although not one in hospital admissions. They also found that there was really no evidence for overall cost savings, something that's disappointing to the payers themselves. Now, many of you may have read not the academic journals or not the trade association or advocacy group perspective, but the popular press, which gave a lot of attention to a study that was published in JAMA, the Journal of the American Medical Association, in February of this year. This was a study that was conducted in Pennsylvania as part of a state initiative that was nominally presented as a patient-centered medical home study. It actually started as a project focused on the chronic care model and improving diabetes care. It had a heavy emphasis on something I'm going to talk about in a minute, which is becoming recognized as a patient-centered medical home. Authors from Rand and Harvard Medical School reviewed the results from one portion of this fairly complex enterprise and reported that there were essentially no improvements in the critical elements that they were looking for, specifically improvements in diabetes care, reductions in costs, emergency department visits, so on and so forth. This, because it was in JAMA and because of the prominence of the group, was picked up in the lay press, and actually for now has really kind of taken over the dialogue, because the soundbite from this study is medical homes don't work. Although there have now been a number of responses to this. In fact, if you look in the Journal of Health Affairs this past month, there was a blog describing a little bit more detail the study. This is kind of the word on the street among those folks who are looking for a soundbite, which is that in a fairly prominent journal, there was a conclusion that a, quote, medical homes project really didn't result in the outcomes that were desired. So it may be worthwhile to step back a little bit and ask what those researchers are studying when they evaluate medical homes, because despite the fact that there are scientific methods applied in meta-analyses and other methods that are applied when various people look at them, there is not, as Sharon alluded to at the beginning, a very clear, unambiguous definition of a medical home. One way that researchers and others, both lay people and government agencies and other payers and purchasers and providers themselves define a medical home is through some sort of external accreditation or recognition. Now, there are a number of entities that recognize, certify, or accredit medical homes. Several are listed on this slide. The one that probably has the largest market share is the AHQA Patient-Centered Medical Home Recognition Program. But in addition to that, the Accreditation Association for Ambulatory Healthcare has a medical home certification program. The Joint Commission has an add-on survey that if the applicant organization passes, gives it a medical home designation. URAC has a patient-centered medical home program as well. So there are lots of different recognition programs. But like many certification recognition programs, there's not necessarily a strong association between being able to pass the criteria and having fully implemented the aspirational goals of those criteria. So in some ways, it's kind of like when you get a driver's license, that gives you some sense that you've read the driver's license book, but it certainly doesn't certify that you're an excellent driver. Likewise, getting a recognition or certification for medical home is not necessarily associated with all of the characteristics that we've described previously. And indeed, many of the studies that I talked about before used as a proxy for being a medical home recognition or accreditation by one of these entities. These, by the way, are not the only ones. Many states have developed their own recognition programs. Sometimes for they're explicitly called medical home recognition, sometimes it's health home or other things. It turns out, though, that there is very little research that shows that recognition itself or accreditation is really associated with the positive outcomes that we are looking for. Indeed, there's more research that demonstrates that there is no association between those things. So the Pennsylvania study that I mentioned at the end that got a lot of attention in the JAMA article by the RAND folks really strongly encouraged the entities. In fact, all of them became recognized by one of the agencies. But after that, they really didn't have to do much to get the payment that was associated with the project. So I think it's just important to keep in mind that recognition, accreditation, or certification is not necessarily the same thing as being a medical home. So we do, by the way, understand and recognize that payers and purchasers need to have some way to recognize a medical home. Our organization, as well as many of those I believe on the phone, have individuals who support recognition of various types. We have a number of NCQA certified content experts on our staff, but we focus on that really as a tool rather than as an end in itself. What's really more critical, actually, in trying to achieve the important outcomes that are associated with a medical home is to focus on ways to both implement and achieve those desired outcomes through some sort of transformation framework as opposed to recognition framework. Now, there are a number of those. TransforMed, which is a division of the American Academy of Family Physicians, has a model. Tom Bodenheimer and his colleagues at the University of California in San Francisco have offered a model that they refer to as the building blocks, actually the building blocks for primary care, but in this case they're really talking about the same medical home concepts. Agency for Healthcare Research and Quality has a number of resources and a model. And what I'm going to be talking about actually is a series of what we call change concepts that were developed as part of a project that I'll describe, but which has now been used in a number of transformation efforts across the country. So for the remainder of this conversation, for the next few minutes, I'm going to talk a little bit about supporting practice transformation lessons that we've learned, but more importantly, just to try and point you to a few places to go if you'd like to learn more about these lessons, because in the time we have, we won't be able to go through them in detail. So where did we learn these lessons? On this slide, I've showed just a few of our patient-centered medical home clients. There are state primary care associations. Just last week, we were working with the Harvard Medical School Center for Primary Care on a collaborative that included 19 of their teaching practices. We're doing some work with the state of Arkansas supporting a state Medicaid improvement initiative. But much of what I'm going to talk to you about came from a project called the Safety Net Medical Home Initiative, which was sponsored by the Commonwealth Fund. This was a 5-year project that endeavored to help 65 safety net clinics. Those included community health centers, homeless clinics, some residency programs, rural health centers, to accelerate that transformation into being patient-centered medical homes. It was not primarily focused on recognition, although many of the practices actually got recognized. It was really focused on transformation. You can see in this slide in the yellow the 5 states that were participating. We worked in each state with a convening group called a Regional Coordinating Center, and administered the project in collaboration with the McCall Center for Healthcare Innovation at the Group Health Research Institute. That's the team led by Ed Wagner, who developed the chronic care model. As part of this, we developed a framework for transformation that included a series of 8 change concepts, high-level, fairly abstract ideas that include domains in which practices need to improve in order to transform themselves into medical homes. Each of these change concepts is accompanied by a series of key changes, which are more actionable things that they can do. There's a reference here which tells you how you can read a peer-reviewed journal article about it. We'll also show you some other references which are on the web that can give you a lot more detail about this series. One important thing about this is you can see that it's kind of layered into different groups, and we actually think there's a sequence in which transformation needs to occur, transformation activities need to occur. If certain things are fundamental, organizational engaged leadership, a quality improvement strategy, an approach that really develops populations by empaneling them, focusing on team development are among the foundational and early things that need to happen. So again, I can't go into this in detail, but just would suggest to you that there are some systematic ways to go about transformation which have been demonstrated to be effective. One of the ways in which this has been demonstrated is by an assessment tool that's been validated and reported in the Journal of Health Services Research. It's called the Patient-Centered Medical Home Assessment. We have a number of implementation guides which include a variety of tools. These are all in the public domain and available free. You can access these things as well as look at a large number of webinars that address various components of this framework at the website that's listed at the bottom of this slide, which is www.safetynetmedicalhome.org. So the quick nutshell of this is all of these are available in the public domain, will be of help both to those who are trying to transform their own practices, but also to those who wish to offer assistance to practices in transforming. Just one quick note is that there is a reasonable amount of evidence now that practices can benefit from external facilitation. This is a Commonwealth Fund issue brief, which is easily accessible on the Commonwealth Fund website. Again, conducted or authored by some folks at the University of California in San Francisco, starting with Kevin Grumbach, who's the chair of the Department of Family and Community Medicine there, which basically finds that external facilitation can assist practices in improving and is very supportive of federal, state, and other programs that can assist practices by providing external coaching and facilitation. There's been a fair amount of work on looking at what works in terms of practice facilitation. The SafetyNet Medical Home Initiative had its particular approach. We have a website listed at the bottom of this slide called coachmedicalhome.org. There's an AHQA white paper on the particular approach we use that's on the other URL here. Again, these are all free in the public domain, and I would suggest that they may be helpful to those of you who are interested in practice facilitation. So again, here's the website that all of those are available at, www.safetynetmedicalhome.org. So in closing, with regard to the question of whether or not medical homes have achieved the high aspirations and expectations set for them, one might look at something that's called the hype cycle. This actually initially was developed by a group called Gartner Research to look at the trajectory of beliefs about various implementations of information technology. And what they said is an event happens, a trigger, people have all kinds of inflated expectations that reach a peak, but because the intervention doesn't necessarily reach all those expectations, there's what they call a trough of disillusionment. But after that, people see that they don't really throw out the baby with the bathwater, have some kind of slope of enlightenment, and at some point, real improvement happens. The green bar here shows what really happens, which is real progress. I would suggest that particularly because of things like the JAMA article that I mentioned, we may now be in this trough of disillusionment about medical homes, despite the fact that there is some promising evidence that the medical home concept is likely to improve the quality of care, satisfaction that patients have, and potentially, at least, I think this is a little bit of an open question, reduce costs for care delivered in primary care. With that, I'm going to suggest that you put your questions in chat because we're not going to address questions until the end of the presentation, and we'll now turn the podium over to Carlin.
Good morning. Thank you, Dr. Sugarman. I really appreciate the information that you shared this morning. We're going to talk a little bit about the Patient-Centered Medical Home Project, and we're going to be talking about it from a perspective of boots on the ground. I'd like to thank AHQA for inviting me to participate in today's meeting, and my segment today is really going to share our organization's experience with its first PCMH project here in Kansas. And during my talk, I'll describe the current efforts and environmental factors that are influencing the development in our state. I'll then share a little bit more about our specific project and some of the lessons we've learned so far, and identify some of the resources and best practices that have helped us with developing a practice facilitation program. So again, we're Kansas, kind of in the middle of the country, and many of you probably associate that with tornadoes or Dorothy and Toto, but I actually grew up in Kansas, but left and went to the West Coast for about 10 years and then came back. So it's one of those places that's kind of a well-kept secret. Most of the country, or most of the state, people just think is purely flat, but there's a little bit of hills here, as you can see from that bottom center picture, and it's just an interesting place. So understanding a few quick metrics compared to national data will perhaps help inform the context of our project. You know, in Kansas, we have 2.8 million population, and comparatively, we're not too far off from the national median. What becomes a little more interesting is when you look at the counties and our distribution of population. We have 105 counties, and a little over 12% of our population is living in 60 of those counties, or to put it another way, only 12% of our population lives in 2/3 of the land area. There are some counties that do not have healthcare providers, and because of the scarcity of health providers, we also have 95 critical access hospitals or CAHs. And for some patients, that's their only access to care. And believe it or not, dental and mental health statistics are worse. So I work with the Kansas Foundation for Medical Care, and it is a nonprofit organization, and our mission is to lead innovation to improve quality, effectiveness, and safety of healthcare. We are the state's Quality Improvement Organization, or QIO. We also have a number of other contracts. We do external quality review, quality improvement, data, and analysis. And the division I work for is the HITRIC, or the HIT Regional Extension Center. Some people just refer to them as the REC. And I joined the REC about 3 years ago, so helping with implementations and helping physician offices meet meaningful use. And that federal grant that we received using stimulus money, or ARA, was designated to help practices in groups of 10 or less. So groups that typically don't have those kinds of resources. And as part of our sustainability efforts, we began recruiting practices for a patient-centered medical home project in March of last year. Prior to our pilot project, our Kansas Academy of Family Physicians led a pilot project with 8 clinics across the state. And of the original 8 to complete their 2-year project, half have received NCQA recognition, and the remaining 4 are now working with my organization to prepare for their submission by the end of this year. So compared to the East and West Coasts, Kansas has been slow to develop patient-centered medical home initiatives. We have 2 payers that are offering incentives for NCQA recognition. One is based in the Kansas City market and has been offering a per member per month incentive, which has stimulated a lot of activity there. All the major hospitals and their affiliated clinics are recognized up in the Kansas City market area. And the only other metropolitan area is Wichita, which is where I'm based out of. And our other statewide payer is offering a small incentive as a % of allowables, and they do plan to increase that over time. But as of 2014, that amount is 0.75% of the allowables, which, as you can do some math there, that's not a very big incentive. We have 13.1% of our Kansas population that's uninsured, and there are no plans to expand Medicaid at this time. In January of 2013, the state contracted coverage for Medicaid beneficiaries to 3 different managed care organizations, so they completely outsourced. And that transition, as you might guess, was less than smooth, and our State Medical Group Managers Association has been kept pretty busy advocating for patients and providers during this change. The state's now launching a Medicaid Health Home initiative, which, as some of you may be familiar, the Health Home model is embedded in the Affordable Care Act. And that's going to be administered through the 3 MCOs. So they're currently engaged with stakeholders as we speak, and they're planning to implement the health homes for 2 target populations starting July 1. And they will be providing a per member per month payment structure for each beneficiary that's assigned to a health home member. And again, as you might guess, those 3 MCOs have each taken 3 different approaches to the contracting and technical assistance aspects. I don't have any official information about the number of participating providers at this time because that's still in development. So that's one of those areas we'll have to stay tuned. My organization just completed a survey last month, and what we found is that more than half of the individuals who responded are interested in or have started the process of becoming a PCMH, and a quarter of those surveyed have been offered enhanced reimbursement or incentives from contracted payers. And with only 1/4 of them reporting that, I take that as maybe some of them are unaware of what one of the major payers is offering. A majority of practices are becoming or considering, the PCMH model to prepare for the pay for performance initiatives and or to improve their quality of care and patient satisfaction. And more than 85% of the largest physician networks are or have plans to become patient-centered medical homes within 2 years. And as I mentioned, we have those 2 urban areas. Everything else is pretty much rural. And the majority of those undertaking the patient-centered medical home recognition process have engaged or will engage external assistance. So I hope that that background information about the state and a little bit about our current PCMH environment will help you understand the context of our pilot project. So as part of the REC, we worked, again, as I said earlier, with small to mid-sized groups of 10 or less providers, and they historically don't have those resources to take on major projects such as EHR implementation or patient-centered medical homes. So we solicited applications from primary care physicians throughout the state to participate, and we did require that in order to participate that they had already implemented an EHR so that we could avoid two major projects competing for resources at the same time. However, working with the Regional Extension Center previously was not a prerequisite, that we did not require that. And we actually received over 40 applications. 6 practices were selected and are geographically distributed around the state. In addition to geographic distribution, the practices are also located in different settings ranging from rural to urban, which we discussed earlier. And as you can see, none of our pilot clinics are currently located in a frontier county, but 2 of them are in rural areas. We also partnered with TransferMed to train the trainer. And because KFMC practice consultants were learning how to facilitate a PCMH project, we also limited the group size of our applicants to a maximum of 4 providers in order to reduce some of the additional project aspects and constraints that might exist with larger groups. So this is just a high-level overview of our project to date. Our kickoff meetings included on-site visits to each clinic, which were more of a meet and greet, and they included a brief discussion about what a PCMH is. And the kickoff meetings were followed by some baseline assessments, which included change readiness, staff and provider satisfaction surveys, and a PCMH assessment. One of the things that we learned is that turning those reports around timely is important, and rather than just coming in and doing a meet and greet, doing more of a getting everybody together, talking about what PCMH is, what this project entailed, and getting the leadership to voice their commitment to the project really was very helpful. And what we ended up doing was having to go back and kind of do that after the fact. And we had a few clinics that were voicing some frustration a couple months in because they weren't getting their reports yet, and what are we doing? And so timeliness and making sure that everybody's ready to go when you pull that trigger, I think, is one of those critical lessons learned. Ongoing practice facilitation includes some monthly or bi-monthly on-site visits to meet with the practice administrators and the PCMH implementation teams or ad hoc work groups, and then, of course, providers and staff. We also have utilized some web meetings when possible, which has been primarily used for planning or joint educational meetings with our pilot sites. And the practices, frankly, have been somewhat reluctant to participate in group meetings, and they really value the one-on-one work with their consultant that's doing the practice facilitation. Also, during this time, we've been building the track ahead of the train, so to speak, and this is referring to the development of our toolkit for facilitating the PCMH projects, and I'll speak more to that shortly. We currently have 2 practice consultants, myself and my partner, Mary Smith, and we're facilitating the PCMH transformation, and we are both certified content experts for NCQA's PCMH program. And since January of this year, 5 more clinics have contracted for our services. 4, as I mentioned earlier, are with our Kansas Academy project that are coming in and just for technical assistance to help them complete their recognition submission. And then one of those is a former REC client who will submit full facilitation, and they plan to submit under the new 2014 standards. So as of today, all 6 of our pilot clinics are planning to submit for recognition, and with most of them shooting for submission this fall. We expect a couple of them will end up submitting after the first of the year, but they're all opting to submit under the 2011 standards. So for those of you who are not familiar with the NCQA standards, there's 2 versions, the 2011 and the 2014 standards. And the 2014 standards were announced in March, and they allow a 1-year overlap period where you can choose which standards you submit under. So if you're down, well into your development and preparation for that, which we're over a year into that project, not having to kind of go back and change everything you've done is a real help. So I would say that the lessons that we've learned over the past year have occurred in 3 distinct areas. There's barriers to actual practice transformation. There's practice realities, and then there's the considerations for developing a practice facilitation program, and we'll talk about each of these in the following slides. So with barriers to practice transformation, any project of this scope involves change, and there's going to be potential barriers or pitfalls. So here are some examples that can be encountered. Leadership commitment is the essential ingredient of any project this size, and that top-down support, setting realistic goals, managing expectations, and having clear communications are necessary. And you would think that that would be easy in a small practice of, say, 1 doctor and 3 staff members, but what you find is they just assume a lot sometimes, and they don't always talk. So, you know, where there aren't formal processes, you almost have to go back and start at the beginning and teach those basic things. With change management, that really is what a patient-centered medical home transformation project is about, and establishing and growing a culture that has a desire to learn as an organization and to do things better, how to minimize conflict, and developing the staff and empowering them to be involved in the process really is what practice facilitation is about. And as Dr. Sugarman discussed earlier, this transformation versus recognition, those are 2 completely different processes, and they can run in parallel, which I am going to talk about briefly in the next slide. That delegated decision-making that's inherent within the PCMH model is embodied with what they call team-based care. And to implement that, it takes the team, not just the managers. And the PCMH implementation team should be representative of all the different areas of the clinic, and you have to consider the different learning needs and concerns. And one of the things we learned very early on is you have to identify who your champions are. So who's your physician champion, who are your administrative, and who are your departmental champions? Because those are the people who are there every day having the conversations about why are we doing this project and trying to have folks make sense out of it. Developing patient engagement, if you really want to be patient-centered, we do have to consider our patients in every decision. And I also have a separate slide that we'll talk about that in a moment. The systems and the workflow redesign, getting past that, we've always done it this way to incorporate new ways of looking at things. For example, population management requires that the clinics pull clinical quality data out of their EHR and then goals to improve their care. And things that they've struggled with includes data collection and obtaining benchmark data and understanding how to utilize their EHR to improve documentation, and then that periodic analysis and review. And that really, frankly, was one of the things that we learned through the Regional Extension Center program is, you know, it takes so much energy to get this in, and when they were focused on meeting the standards for meaningful use, the last thing they were doing was looking at their quality data. So when we had clinics coming around for year 2 or year 3 assistance, that's when we would try to help refocus their efforts and say, you know, now let's look at your clinical quality measures. Why is your smoking cessation at intervention showing 0 in the numerator? You're talking to them, but you're not pushing the right button. You're not documenting it in a way that the system recognizes it. So things that, you know, larger clinics, they have dedicated staff to help make happen. These small clinics don't. So, you know, all of these things take time and resources, and those are scarce commodities in these small to mid-sized practices. So regardless of the accrediting body one chooses, recognition is really the administrative dotting I's and crossing T's, whereas transformation is the actual process of evaluating and implementing that change. And the transformation process requires managing change well, which we've discussed, but it can be a barrier if it's not done well. So if you come away with nothing else today, understanding that difference is really, I think, critical. And being patient-centered, as Dr. Sugarman says, does not require accreditation. But transforming a practice does not have to result in the recognition or an accreditation at the end of the project, and it is an ongoing process. It never ends. And again, so these can run in parallel, but they have different time frames, and each will have different barriers or program support needs. with patient engagement, there are a number of ways, and I'll just give you a couple of examples. For quality improvement initiatives, we typically do the patient satisfaction. But one of the things that I was exposed to as an executive director for a safety net is 50% of your board has to be comprised of consumers, the people who are actually using your services. And I found that to be a little intimidating first going in, but after experiencing it, I'm able to share with my clinics now and say, you know, that's one of the best experiences I ever had as a clinic administrator, because getting the feedback of your patients, it's almost like a secret shopper. They can tell you what's working and what's not working. And if you do a good job of selecting those folks, they're going to give you really great feedback. They're going to be not, I want this better just for me. They're really concerned about everybody. And they really don't come in and try to take advantage of, you know, what kind of favors can you do for me because I'm on your board. So, and that's some of the pushback I've gotten from some of our clinics. Creating processes which allow the patients to become invested in their own care, you know, the tools and the education and online access and all of that is really, there's so much work and effort going on out there. You don't have to recreate the wheel. There's now a society for participatory medicine, and we're referring to these patients who have electronic access as e-patients. Integrating the patient and family perspective into their planning, again, having the cultural and linguistically appropriate and using the motivational interviewing and goal setting. Your operations redesign, obviously, that's pretty self-explanatory. But there's really some unique ways that patients can be engaged more fully. If you have them come in and talk about their experiences, that can help inform your staff, that can inspire them and energize them to do better. And then, you know, some of these challenges are going to be changing your culture to support that and dedicating the staff time to support and liaison with patients and recruiting and training them so that they understand healthcare to the extent that they can make suggestions that you're going to have to educate them. And then being times that are convenient to them and all of the meeting planning and, you know, materials that go into that really takes some time and energy to make it happen correctly. I mentioned practice realities. We found that most of our clinics didn't even have a mission statement. So if they didn't have a mission statement, the chances of them having a quality improvement plan were pretty much zero. And again, you have to meet the clinic where they are. You have to start with where you're at. And the lack of, I do think a lot of regular communications and training and a consistent or intentional approach to quality improvement can prevent a practice from being truly patient-centered, whether they have written, documented processes or not. And then, of course, the limited resources. So they just don't, they deal with the realities of limited resources every day. And it's important as a facilitator that we understand that. So, for example, if we ask them to require an all-staff meeting, it requires that they usually shut down the clinic. And if they want to avoid overtime, results in lost revenue, you have to keep in mind that they still live in the fee-for-service world. Or you could meet with them before or after office hours or even during lunch, which may cost them overtime or the expense of time and meals. So another example is some office managers in these small practices may not have a college education and not familiar with our managerial jargon. So on top of that, they're usually working managers, which means that if the receptionist calls in sick, they have to cover. So being flexible and supportive is critical, and when it happens, having had some conversation in advance really helps everyone know what to do. So are we going to reschedule? Are we going to move to a different time? Are we going to keep work moving despite what I call those activities of daily life? I mean, people get sick, people go on maternity leave. I mean, there's always something going on, and we have to really have an infrastructure in place that'll help us keep moving. And I'm watching time. We've got a few more moments here. So considerations for developing a practice facilitation program, you have to keep in mind the demographics of your environment and the context in terms of the size of the practices that you're going to work with. And, you know, with limited payer support, at least in the short term, we suspect our funding will come from grants or payer-led initiatives or the fee-for-service work that we're starting to see. But based on some requests for information from CMS and some of the current literature, we're hoping that funding similar to the Regional Extension Center grants will become available. So we're going to continue developing, identifying tools and methods, and with staffing, you have to get the right skill sets, and there's a host of literature out there, and I'm going to give you that in the next slide. AHRQ has developed a really good couple of manuals. One is developing a practice facilitation program, and the other one is facilitating PCMH in your practice. And so getting those right skill sets and making sure that you have enough facilitators to practice ratios established is going to be good, and your ongoing skill development. And are you going to do transformation versus just the technical assistance for recognition? And will you use on-site or remote? One thing that we've learned is that if you don't develop trust with the providers and staff, you're not going to motivate them to change. So understanding how your delivery model will impact that is pretty important. And understanding how your model is going to work in order to predict your revenue and cost also is critical. Tools and resources, again, identify experts and best practices, and you shouldn't have to reinvent the wheel. And I have to say that's kind of one of the best things about being in the middle of the country is we're kind of insulated, and we tend to be later in the adoption of new payment methodologies and things, and we get the benefit of watching the East and the West Coast and kind of learning from your lessons learned. So, again, KFNC is still finalizing our tools and interventions as well as developing an appropriate strategy for disseminating them to other stakeholders. And for those of you who are looking for a place to get started, I highly recommend checking out these resources. As I mentioned, the two facilitation manuals from AHRQ are listed first. IHI is another great place, and not to I didn't realize Dr. Sugarman was going to talk about the Safety Net Medical Home Initiative. We came into that several months into our project, and it's been extraordinarily helpful in us developing our facilitation program. And there's a new healthit.gov video that you may or may not have seen. I recommend that. That's a really good job of explaining kind of what's going on nationally to your stakeholders. And then, of course, the Robert Wood Johnson Foundation and their support for the Forces for Quality, which deals with patient engagement. Really good resource there. Just references and contact. So I will turn it back over to Dr. Eloranta. Thank you very much.
Thank you so much, Jonathan and Carlin. We have a few minutes left, and I've got my pick of a number of very interesting questions. I think I will start a little bit of a combo question, but I would start with Jonathan. Wanting to know the difference between person-centered medical home and, quote, population health. Kind of what do you perceive the differences are in those?
So without going into kind of a long-winded definition of the two, I think there is certainly some overlap. Our view of patient-centered medical homes is that one of the key elements of designing a practice is to think of the patients in the practice as a population. If you go back to the slide that we showed with the framework, you'll see that early on was the concept of empanelment, which enables population-based care. I guess the short summary I would say is that medical home implementation, medical homes are a method of improving or addressing population health. The difference between the medical home and usual practices, typically usual practice is focused on only individual patients. The medical home focuses on both individual patient care and proactive care to an entire population. So they're not completely discrete, separate concepts. I would think of the medical home as one method of addressing population health. For instance, in accountable care organizations, which are responsible for health of populations, one of the elements that is thought to be necessary to make them successful is to have a strong primary care base and to use a model that has features of the medical home in accomplishing the goals of the accountable care organization to improve population health.
Great. So here's another question, and I guess I would ask you each to cover it quickly. I think Carlin just mentioned this, but kind of asking what's in it for patients in the person-centered medical home, and how does the approach to patient engagement differ when you're in a person-centered medical home versus usual care? And I don't know if, Carlin had a whole slide about kind of patient engagement. Did you want to amplify on that at all?
Certainly. I think, with patient engagement and maybe touching a bit on the empanelment and the population health management, sorry, that thought was there and I had it going and now so let me just try to rephrase that. With the patient engagement, the patients need to understand what they can expect from the practice, and they need to understand what you expect them to do. So communicating with them and educating them so that they know if you're seen in the emergency room over the weekend, I need to know that you were in the emergency room over the weekend. You need to call my practice Monday morning and tell me so we can get your records and we can do your follow-up care. And same thing with inpatient admissions. If you were admitted, let us know. We're also going to have that proactive process in place, hopefully, with our hospitals where we're being notified that our patients are there so that we can then follow up on them after discharge and make sure that we get them in and avoid that readmission. But with the patient engagement, we want to make sure that we're giving them the information they need to manage their care well, and that they know that there's a mechanism for telling us and giving us feedback about what they need, what they want, and if they're not getting what they're expecting, and helping encourage them in meeting their goals. So setting goals for their care, helping them meet that. And with the population management, the only patients we can impact are the ones we're caring for. And so, in my opinion, the medical home model is key. We're still going to have that episodic care where we're seeing the patients when they call and need to see us, but with medical homes, we're integrating more of we're taking a step back, we're running data out of our EHR, and we're sending recall notices to patients and reminding them, you know what, it's been 3 months since you've had your hemoglobin A1C for your diabetes. It's time for you to come in and have your test done again. Or it's been a year or plus since you've had your last mammogram. It's time for you to come in and get that done. Or here's your order. Let us know if you need anything. So again, interacting more with the patients and helping give them the information either through our portal or through handouts when they're in that helps them understand their chronic care conditions or what preventive services they need.
Great. Okay, that's really great. Thank you for all that good information. So we have several more really good questions. So if you could answer quite succinctly if possible, and this is a hard one to answer succinctly, but maybe Jonathan, could you start with this one? I have a couple that are kind of around the topic of the relationship of the payment model and PCMH. One of the questions said, how does the current fee-for-service model of payment impact PCMH? And another talked about a per member per month type of payment. What do we know about research or experience talking about the reimbursement system and the model?
So that's a pretty hard question to ask succinctly. I'd say the bullet responses are, it's very clear that the solely fee-for-service model is not consistent with delivery of some of the services that are fundamental to the medical home. Care coordination, the time for quality improvement measurement, and things like that. That said, there are many fee-for-service practices that have implemented the medical home model and done it very effectively and are able to do it in an economically feasible way by improving their team functioning, having physicians do more physician work and less administrative work, looking for medical records or things like that. So I guess on the one hand, it's true that the fee-for-service model is not consistent with full implementation of the medical home. On the other hand, we've seen many practices in different reimbursement models that have been able to effectively implement various components of the medical home. With regard to research about the impact of various payment models on medical home implementation, a number of the projects that I described earlier on were part of pay-for-performance or alternative payment programs, and the data are equally disparate among those in that some of the payment programs, there have been a couple by large health plans that have claimed at least substantial improvements in quality as measured by various process measures and decreases in costs by per member per month payments or care coordination payments. Others have not found that kind of thing. So for instance, the Pennsylvania one I talked about, physicians, I believe, got an average of about $93,000 for being in the project and getting NCQA recognized, but that was the one that had very little impact on, well, really no impact on quality or costs. So it's quite variable is I'd say the bullet point answer to that question.
And that is a hard one to answer in bullet points. And I did want to call out that Dr. Mims has notified everyone that the panelists have agreed to stay on for a few more minutes to answer a few more questions. So we have a few more. Here's one that I would like to get both of you to answer kind of in the succinct manner, which are kind of what are the main characteristics that are important for a medical home facilitator, and what do those facilitators do? And again, this maybe doesn't lend itself to bullet points, but Carlin, if you could give us your words of wisdom on that.
A practice facilitator is much like a coach, and they are there to provide education on best practices and the concepts that fall within the medical home model. They're there to be a cheerleader so that when staff get confused or frustrated, that they're encouraged for the changes and the accomplishments that they're making. And I also think that they're a project manager because they also have to understand, you know, what's critical, what are the things that, you know, aren't as critical, and helping the practice kind of chunk it down into bite sizes so that, you know, if you look at a transformation project, you know, that's going to take a year to 2 years to complete just the initial push. And then it's ongoing after that. It should become part of the culture. But to take a project, let's say with the end goal of submitting for recognition, you have to work them through different aspects of the project, very much like the Wagner model that Dr. shared earlier. You have to build on the basics, you lay the foundation, and then you keep building on that. And having that plan and having the ability to help the practices navigate through that, I think, is pretty critical. So having a fund of knowledge about clinic operations and having a fund of knowledge about quality improvement and change management, in addition to some of those other aspects, I think is probably pretty important.
So Jonathan, do you have anything to add to that? And also, can you give your estimate of kind of the time expectation you would say that it takes for this transformation to occur? We heard from Carlin.
Okay, so two pretty different questions.
Yeah.
I guess one thing I would say is there are lots of different types of characteristics that can support a good practice facilitator. We often use teams, though, because no single individual can have both the topic area knowledge about some technical issues related to empanelment or things like that, as well as deeply evolved change management and project management skills. So lots of different kinds of people can do it. There's actually fair literature, and in the references that Carlin put up and I did, I think it would not do service to that literature by just giving a very quick answer. With regard to the time, I guess I would say it takes a long time, actually, to really achieve transformation. Even, by the way, just to achieve recognition, which doesn't necessarily require transformation, that there seems to be, if you're starting from a pretty usual care practice, at least a couple years required, even just to get kind of the general approach put in. We've had projects ranging from a year or two to 4 or 5 years. The SafeNet Medical Home Initiative worked with the practices for 4 years, and they continued to progress. In fact, fully half the practices that ultimately reached some important medical home milestones, did not do so until the second half of the project. So to use the hackneyed analogy, it's really a journey. It takes a long time. It's a continuous journey. Even highly functioning organizations that have implemented many of the medical home precepts continue to evolve them over time. So the one kind of key finding or key message from that is that pilot projects that last a year or so and don't start with practices who are fairly far along in their evolution are not likely going to achieve the goals that they're looking for.
So great answers. One more. This is really intriguing. We're asked with kind of the potential for use of basically telehealth, so patient self-monitoring, communication with physicians without face-to-face visits and so forth. Can't a cell phone or tablet actually become the PCMH of the future?
So I would say that cell phones and tablets are tools. Many medical homes use technology in a variety of ways, patient portals, texting for both clinical preventive services types of things and appointment reminders. I think that, though, is a far cry from actually having those devices serve as the medical home. In the same way that electronic health records, which were kind of projected by many as being the solution to every problem in healthcare, where the reality is that they perhaps add some incremental value but also bring along their own constraints, that those things are tools that can be well used. In fact, some of our medical homes use telehealth. They use televideo for psychiatry consulting when they're in rural areas and don't have access to them, or use some kind of remote monitoring. But I think that's a little bit different from saying that they're going to be, that those devices actually serve as the medical home.
Great. I'm getting encouraged by Dr. Mims to go for a couple more questions. We do have a couple more. Carlin, I wondered if you could comment about kind of an optimum team size or composition. As you were talking about, you have some teams that are very, very small in order to become a PCMH, and kind of hooked onto that, have you seen this work in very small solo practices?
Yes. One of the examples I gave earlier about a single physician and 3 support staff, they're all on the PCMH team because one is the business manager / biller, one is the receptionist, and one is the nurse. And so you do have all the aspects of the practice represented that way. In one of my larger practices that has several physicians and has about 30 employees, we have a team of about 8. And that represents the providers, that represents the billing and administrative and reception staff, and then we have a couple of nursing and an ancillary member that represents the lab and imaging in their office. So again, it really needs to be, as long as it's representative and you don't get it to be too large, I think that you'll find that then it can be quite functional.
Great. And one final question, I guess, for Jonathan. Would you say that the person-centered medical care home model could care for frail seniors or folks that actually live in alternate settings, say assisted living, skilled nursing facilities? Do we have any experience with that, or what do you think?
Sure, and many of the medical home pilots have been focused on people with multiple chronic conditions. I'm not quite sure what the focus of the question is. Often those people have complex needs. As I mentioned at the beginning, the whole medical home model came from pediatricians who are trying to deal with children with special health care needs. It's actually in many ways more important for people who have complicated conditions to have a quarterback for a team who really take responsibility for coordinating the care among various specialties other than primary care. So it's certainly for the first group, the frail elderly, something that is an appropriate model. With regard to people who live in assisted living facilities or nursing homes, there are kind of probably versions of the model that would be appropriate for people in nursing homes, and clearly the responsible providers can implement many of the elements of the medical home model. I can't off the top of my head, though, think of a large pilot that's focused primarily on people who are living in that sort of environment as being evidence that the medical home is an appropriate model for that population.
So great, thank you so much. And I'm about to hand it back over to Dr. Mims, but she had seeded another question about kind of relationship to 11th scope, and for those of you that are on the line from the QIO program, just the next contract in quality improvement organization work. And it really sounds like, particularly based on Jonathan's previous answer, that there are connections between developing this transformation to person-centered medical home for caring with the populations we're supposed to take care of, those with complex medical conditions, potentially opportunities for looking into how these concepts could be embodied with skilled nursing facilities with their, medical structure that they have, certainly with the care coordination that both Jonathan and Carlin mentioned in the reducing rehospitalization, improving care transitions work. So I think these concepts are broadly applicable. So Dr. Mims, did you want to wind up the meeting?
Yes, thank you very much. This has been an exciting conversation coming from different perspectives, and I appreciate that people have stayed on the line making sure that their questions were answered. Thank you very much for participating. As you close out of the screen, you will be prompted to fill out an evaluation to give us feedback on how we can improve and what your interests are. So please do that. And those of you who are looking for continuing education credit, you will also be linked to our webpage where you can download the CME application and complete that. So thank you very much to Drs. Eloranta and Sugarman, and for Karen Hari. You've done an outstanding job today. Thank you all for attending. Goodbye.